Good evening, everybody. This is Dr. Sanjay Agarwal welcoming you to the IDEC Cafe. We are really privileged and honored to have three stalwarts with us today for this program, which we kick off today for the first time. And we have a series of these programs to follow. IDEC has always believed in great scientific discussions, and nothing can be better than having three great stalwarts of the world with us today to discuss all about pre-diabetes and insulin resistance and the role of metformin in these conditions. We have Dr. Ralph DiFranzo, Dr. Anup Mishra, and Dr. Ramchandran, each of them a wonderful person and a luminary in their own right. IDEC was conceived about 5 years back, and over the last 5 years, we've had a lot of great meetings and our flagship meeting every year, which draws people from all over the world to join in and listen to great scientific discussions. I'm going to let Dr. Neeta Deshpande, my colleague, do the rest of the talking all about IDEC. So over to you, Neeta, for continuation.
Yeah, thank you, Sanjay. I just want to give you a brief about IDEC, which was conceived of about 5 to 6 years ago with the intent of bringing the best research minds. And we had an idea of bench to bedside, and we tried to get the best cutting edge lectures to our physician friends across India. And to that end, we've had 6 international conferences so far. And our signature programs have been keynote lectures, nutrition symposia, and research methodology workshops, and several such other flagship items that we have brought to the public. So we hope that this IDEC Cafe, in the same vein, will bring about a lot more academics to everyone out here. And please stay tuned for IDEC Cafe, because we're going to bring you some of real cutting edge research and some of the best speakers in the world at your doorstep. So I want Anjali to speak a few words to take this forward.
Thank you, Dr. Sanjay and Dr. Neeta, for setting off the stage. It's a privilege and pleasure to be part of IDEC. For last 6 years, we have been doing wonderful academics. And today I have the pleasure and privilege of introducing the stalwarts for the today's cafe. The speakers, Dr. Ralph DiFranzo, Dr. Anup Mishra sir, and Dr. Ramachandran sir. So I don't think anybody in diabetes working in India and abroad doesn't know these figures. Dr. Ralph DiFranzo, as we know as the father of the pathophysiology of diabetes that we understand today, the person who conceptualized diabetes hominis octate, professor of medicine and chief of diabetes division at University of Texas, Banting Award from ADA, the Bernard Award from ESD, the Ham International Prize in 2017, more than 800 published articles in high impact journals. And we all know that his major interest lies in the pathophysiology of diabetes. Another speaker we have Dr. Anup Mishra, a visionary from India, executive chairman, Fortis CDOC Hospital, has been the former professor of medicine in AIMS, New Delhi, more than 3,000 publications at the editorial board and the chief positions of very important journals like Diabetes and Metabolic Syndrome, Journal of Diabetes, a member of Academic Board of British Medical Journal, and very prestigious awardee of Padma Shri Awards and BC Roy Awards, and an author of book Diabetes with Delight for the patients and their relatives. And we have another visionary, Dr. Ramachandran, who is internationally acknowledged a pivotal figure in the field of contemporary diabetes healthcare and research. We know about his diabetes center in Chennai, the great work and the clinical work that he's doing in his center, as well as the Indian Diabetes Research Foundation, IDRF, that also we all are very aware of, a very passionate clinician and academician. With that, I will hand over the proceedings to Shilpa to take the program forward.
Good evening, everybody in India, and good evening, everybody in the United States, whoever is watching. And thank you so much, Anjali, and thank you, Dr. Sanjay and Dr. Neeta, for having me here. I would request Dr. Archana to take forward the proceedings.
Thank you, Shilpa. Thank you so much. So we have heard the IDEC team telling all about the vision and how IDEC was conceived to bring science from bench to bedside. So we were doing so many conferences over the years with great science, but we felt it were too far apart. So when we were meeting in our last together, we were just pondering how can we connect better and how can we talk about the current topics. And these are the burning topics happening every day, and we are waiting for a year to talk about them. So we thought, let's do something which is catch people after their long clinic hours. Let's talk science. Let's have a good panel discussion, a lot of brainstorming, which would be relevant the very next day when we go back to our clinic. So with that thought was the Wednesday Cafe born. So we are going to continue our Wednesday Cafes from IDEC. Every month, we are going to bring you a current topic which is burning, which is relevant, and which is something which will change the way we practice the next day in our clinics. So with this much of introduction from the entire team of IDEC, I warmly welcome our speakers who have been so graceful and honored us at this shorter notice, and all our delegates who are attending. With this, I would like to invite our first speaker, none other than Dr. DeFronzo. Over to you, sir. A warm welcome.
Great. I am here in San Antonio. It's morning here, but I know it's evening in India, and it's a great pleasure to be with you today. I think you in India realize that diabetes is a big problem. Worldwide, there are about 550 million people with type 2 diabetes. And according to the most recent information from WHO, World Health Organization, India actually has the largest number of people with diabetes type 2 in the world. Running closely behind is China. And for every person who has overt type 2 diabetes, there's about 1 to 1.5 people who have pre-diabetes. And I don't like the term pre-diabetes because basically the pathophysiology of pre-diabetes is the same as diabetes. Your A1C may be 6.4, so you said that you have pre-diabetes. But believe me, an A1C of 6.4 is no different from an A1C of 6.5. So when we talk about treating pre-diabetes, we're really going to be talking about treating type 2 diabetes, and the same pathophysiology applies for these people. So let's get started. Just so that we understand what we're talking about in terms of diagnostic criteria, there are 3 ways in which we make the diagnosis of prediabetes. The sort of standard way that's been around for many, many decades is to do the oral glucose tolerance test. Of course, if your 2-hour glucose gets to 200, you have diabetes. If it's less than 140, you are considered to be normal glucose tolerant. So we have this range between 140 and 199, which we refer to as impaired glucose tolerance. Now, people are reluctant, lazy, whatever you want to call it, to do OGTTs. So many years ago, a ADA panel of which I took part in came up with a diagnosis of prediabetes based on the fasting glucose. And we called this impaired fasting glucose. And if you have a fasting glucose 126, you're diabetic. Less than 100, you have normal glucose tolerance. So we have this category of IFG that's 100 to 125. And as I'm going to show you in a few moments, IGT and IFG are really very, very different diseases, although they're used in my opinion, inappropriately to indicate the same kind of pre-diabetic predisposition. And then lastly, to make life even easier for physicians, we have established a newer category based on the hemoglobin A1C, 5.7 to 6.4 being the pre-diabetic range. But as I said, if you have an A1C of 6.4, that really isn't any different from an A1C of 6.5. So again, when we talk about pre-diabetes, I want to emphasize, and I'll take you through this in a moment, that the pathophysiology of pre-diabetes really is in fact the pathophysiology of type 2 diabetes. So we're going to have 3 messages to start with. And the first message is that IFG and IGT are two very, very distinct clinical entities, and they have very different prevalence. There's actually a very low overlap. And that's very obvious if you just look at the oral glucose tolerance test in these individuals. So look at the yellow curve. These are people with impaired fasting glucose. They start with an elevated fasting glucose. In the diagram to the left, you see it's 110. You see there's a very quick rise. In fact, the rise in glucose oftentimes goes well above 200. But then at 2 hours later, you can see that the fasting glucose has returned to its starting level of 110. That's impaired fasting glucose. Let's look at IGT, impaired glucose tolerance. These people start with a normal fasting glucose. Of course, something that's very, very different from the IFG group. And then you do the glucose tolerance test, you see the glucose rises progressively, and at 2 hours, it's well above where you started. So if you knew nothing about pathophysiology, if you just looked at these two curves, it would be very obvious that the pathophysiology has got to be very different. So let's start with impaired fasting glucose. Impaired fasting glucose, and this is summarized in the right, is insulin resistance in the liver. The liver overproduces glucose through the sleeping hours. You have an elevated fasting glucose. Now you ingest the glucose meal and there's a defect in first phase insulin secretion. So you get an excessive rise in glucose. And in addition, because there's a defect in first phase insulin secretion, you don't suppress hepatic glucose production. But because muscle insulin sensitivity is normal and second phase insulin secretion is intact, you can see that the glucose returns to its starting fasting level. Now, with IGT, there's a defect in both first and second phase insulin secretion. And so during the first hour of the test, because we're losing first phase insulin secretion, glucose rises. During the second hour of the OGT, glucose continues to rise because there's a defect in second phase insulin secretion. Now, in addition, there's muscle insulin resistance. And so this elevated glucose level, which would normally, the glucose would be taken up and disposed of in the muscle, is going to continue to rise. So the pathophysiologies are very, very different. And it's very likely that the treatment of these two diseases in terms of the medications are going to be very different. And we have a very large grant now in its 5th year to see which medication is going to turn out the best for the treatment of these two distinct entities. I'm not going to be able to share those results to you because it's a blinded study. And of course, we're in the 5th year and haven't completed the study yet. Message number 2 is that IFG and IGT have a very high and very similar risk of progression to type 2 diabetes. These are data that Dr. Abdul Ghani, myself, and Leif Group have generated from the Botnia study in Sweden and from the San Antonio Heart Study, SAHS. This is the 7 to 8 year incidence rate of diabetes, and the incidence rate in people with have NGT, you can see, is quite low. If you have IFG or IGT, there's a significant increase in the development of type 2 diabetes over this 8-year period. But the increase is very similar, whether you have IFG or IGT. And then if you have combined IFG and IGT, you have the highest incidence. So having both an elevated fasting glucose and an elevated 2-hour glucose, the 4th line here, markedly predisposes you to develop diabetes over the next 7 to 8 years. And message number 3 is that IGT, not IFG, is associated with increased cardiovascular risk. Impaired glucose tolerance, as I said, is a disorder of insulin resistance in the muscle. This is the metabolic syndrome. And the underlying insulin resistance and all the components of the metabolic syndrome contribute to its association with an increased risk for cardiovascular disease. Now, there's been a long-standing controversy as to how we're going to treat people with prediabetes. And that controversy is the 2 Ds, diet versus drugs, okay? So the question is, and I'm going to try to answer this question, at least from my perspective, why should we be using pharmacologic therapy to prevent the development of type 2 diabetes? And the answer, in my opinion, is really quite simple, because non-pharmacologic therapy, which is diet and exercise, simply does not work. And the last line here is the important thing, on a long-term basis in the real world. So as I'm going to show you, there are many, many well-designed studies that show that if you lose weight and you exercise, that clearly is the best treatment in the world for preventing prediabetes from going to diabetes. On the other hand, these are well-designed studies with close monitoring, investigators talking to the patients on a weekly basis, nurse practitioners, etc. This is not what happens in the real world. So in the real world, the introduction of diet plus exercise really doesn't work on a long-term basis. So let me show you that if you can get people to lose weight, it really is quite effective. So this is the diabetes prevention program. There were 3 arms. There's a 4th arm I'll come back to in a second. 3,200 individuals in these 3 arms. So these people had a diagnosis based on the OGTT of being pre-diabetic, and then they were randomized to 1 of 3 therapies. Standard lifestyle changes. You see a dietitian, maybe a little bit of follow-up, but I refer to this as lifestyle light. What's going to happen in the community? Intensive lifestyle change, which is very intensive, and I'll show you what this is involved. And the 3rd group is metformin, and then these people were followed up for 3 years. So you can see diet and exercise is fantastic if you get people to stick with the regimen. So in this pre-diabetic population, if you were in the intensive lifestyle group, there was a 58% decrease in the conversion rate of prediabetes to diabetes. And as I said, this is great therapy. Now, metformin was half as effective, 31% decrease in the conversion rate. So clearly, diet and exercise beats metformin. At this point, I also want to mention that there are a lot of misconceptions about metformin. So as you know, I brought metformin to the United States single-handedly in 1995. Metformin is not an insulin sensitizing drug. That is a major, major misconception. Metformin works at the level of the liver to inhibit gluconeogenesis. It does not improve insulin sensitivity in muscle. It has no effect on the beta cell. In fact, metformin gets into cells through the organic cation transporter, and the organic cation transporter doesn't exist in muscle. So metformin can never, ever even enter the muscle. So it's impossible for metformin to be an insulin sensitizing drug. Now, it turns out that there was a 4th arm in the diabetes prevention program, and that was troglitazone. But because of side effects, troglitazone was pulled from the study and after a year and a half. So we're going to look at the 4 arms, and we're going to look at the cases per 100 patient treatment years of prediabetes going to diabetes. And you can see lifestyle light. This is the highest conversion rate of prediabetes to diabetes. Metformin does quite well, but lifestyle heavy does better than metformin, not expected. But the best drug was troglitazone. And I'm going to show you that over the years, troglitazone, or actually thiazolidinediones, have proven to be the most effective drug for the prevention of prediabetes going to diabetes. So let's take a look at the DPP study in more detail. So you can see here in white, this is the placebo, and this is the change in body weight. Placebo doesn't really do anything to body weight. Metformin, there's about a 2 kilogram body weight loss that persists. And then in lifestyle, you can see this really quite impressive reduction, 7 kilograms of body weight. So about 15 pounds. But you can see after the first year, that people are starting to regain the weight. So there was a reintroduction of the diabetes prevention program at 3 years. But despite this intensive reintroduction, you can see that the people continue to lose weight. And over the next 5 years, they're basically doing no better than the metformin group, a little bit better than the placebo group, but still they've regained the majority of the weight. Now, how did this study take place? Okay, well, these individuals, before they started, had 16 core session curriculum meetings, which were taught by case managers on a one-on-one basis over the first 24 weeks. I don't think there's anybody who's listening in possibly lives in a community where you can do this, and no one's going to pay for it, quite frankly. And then after that, they had monthly one-on-one sessions as a group, as well as individual sessions if necessary. Then they were enlisted in an exercise program. It's 150 minutes per week. This is really 5 days per week times 30 minutes with individualized supervision. Boy, I'd love this. My diet counseling, every week, and then I go to see this exercise therapist. It works me out 30 minutes a day, and I don't have to pay for it. Wow, fantastic. Okay. And then after 3 years, because it was observed that people were regaining the weight, the program was reinstituted. Now, that's pretty intensive, and I don't think we can do this in the real world. Now, despite, and this is hidden in the publication, despite the successful weight loss of about, which was really quite significant in many of these people, 40 to 50% of the individuals with IGT still progress to type 2 diabetes. So even though many of these people lost a good amount of weight, half of the people still progress to IGT. So weight, of course, management and exercise program is critical for all of our pre-diabetic patients. But in my opinion, we're going to have to do more than that. And we're going to have to use drug therapy. Now, I'm going to use this study with a drug that was submitted to the FDA many years ago for approval for weight reduction. It's called rimonabant. It was amazingly effective, as I'm going to show you in a second, but it had some CNS side effects, so it didn't get approved by the FDA. So there was a placebo group here, and you can see over the 120 weeks of treatment, with diet, they lost about 2 kilograms. Now, the group that was treated with rimonabant, you can see over the first 60 weeks, they lost 8 to 9 kilograms. Now, the people, when they were enlisted in the study, they were told if you're in the rimonabant arm, after about a year and a half in the study, half of the people would continue on the rimonabant and the other half would be switched to placebo, but you wouldn't know who was going to continue or who's going to switch. So you can see here at about 60 weeks of treatment, the people on rimonabant who stayed on rimonabant continued with the 8 kilos of weight loss. The people who were switched to placebo regained 100% of the lost weight. This shows you the dramatic impact that some of these obesity drugs can have on weight loss. And we know that if you lose weight, that's really a fantastic way to prevent prediabetes from progression to type 2 diabetes. Now, what about pharmacologic therapy? Well, it really does work. So there are 3 studies with metformin. There's the US Diabetes Prevention Program, there's the India Diabetes Prevention Program, and the Chinese Diabetes Prevention Program. The US was the largest one, the Chinese study, the smallest one. The duration is about 2.5 to 3 years. Now, if you look at the reduction in the risk of going to prediabetes to diabetes, I believe that China one is the outlier in all of the data that I'm going to show you. Metformin, I think the Indian, your country, the Indian Diabetes Prevention Program and the Diabetes Prevention Program in the US, about a 30% reduction is what you're going to get with metformin. Now, if you look at the TZDs, to me, a very different story, whether it's troglitazone, rosiglitazone, or pioglitazone, very dramatic 60 to 75% reductions. I'll come back and talk to you about the ACT-NOW study, which is our study. We know that both archibose and volubose particularly in East countries where they're on high carbohydrate diet, rice diets can be very effective, not as effective in westernized countries. And we know with Zendos, with orlistat, and then more recent study, the scale study with liraglutide, very impressive results, particularly with the GLP-1 receptor agonist. And I would say that from the pharmacologic standpoint, the two most effective drugs are the GLP-1 receptor agonist and the TZDs. Okay, so let's take a look at the ACT NOW study. We screened 1,850 people to come up with 602 people with IGT, and they were equally divided into placebo and to glitazone groups. And you can see here, now this is a Kaplan-Meier plot of the development of type 2 diabetes in these pre-diabetic individuals. And you can see 7.6% conversion rate to diabetes in the placebo group, yellow, 2.1% in the glitazone group, hazard ratio 0.28, meaning there's a 72% decrease in the conversion rate of pre-diabetes to diabetes. Incredibly effective therapy. Number needed to treat. You needed to treat 18 people with IGT for 1 year to prevent the development of 1 case of type 2 diabetes. Now, if you have a myocardial infarction and I put you on a statin, the number needed to treat to prevent a recurrent MI with the older statins is about 45. With the newer statins, is about 20. So glitazone in this study was as effective in preventing diabetes, which in my opinion is a serious disease, as are the New World statins in preventing recurrent myocardial infarction, which I think is a good way to look at it, how effective this therapy is. Now, during the study, during the OGDT, we calculated the Matsuda index of insulin sensitivity in the placebo group, no change. In the glitazone group, there was a significant improvement that, as I said, this is primarily an effect on the liver, okay? And then we calculated the gold standard index of beta cell function. This is the increment in insulin divided by the increment in glucose, all factored by insulin resistance. The Matsuda index is the inverse of insulin resistance. And you can see this huge increase in beta cell function. So metformin improved insulin sensitivity in the liver, and it improved glitazone improved insulin sensitivity in the liver and the muscle, and it also improved beta cell function. I think maybe I said metformin, but we're talking about glitazone here. So unlike metformin, which only works in the liver, glitazone works in liver and muscle and has a huge effect on beta cell function. So here we're going to plot now the log of this index of beta cell function. This is the insulin secretion, insulin resistance index against the incidence of diabetes. So no change, the neutral point is 0. You can see all the yellow points here to the right. Who are these people who had really very little development of diabetes? These are the people treated with glitazone. If we look at the orange curve, these are the people assigned to the placebo group. So from the standpoint of prevention of diabetes, the most important factor is what happens to your beta cell function. Sure, improvement in insulin sensitivity is important, and it is a predictor of prevention of diabetes. But compared to improvement in beta cell function, it's really quite small. So, drugs which affect beta cell function, and this is very true of the GLP-1 receptor agonists as well, have a huge effect in preventing the development of diabetes in pre-diabetic individuals. Now, I told you earlier that individuals with pre-diabetes are at risk to develop cardiovascular disease. So is there any evidence that if we treat the underlying insulin resistance, which is a major cause of the atherosclerotic cardiovascular disease, that we can reduce the incidence of cardiovascular events in pre-diabetic individuals? And in fact, we actually have a very good study, the IRIS study, which tells us that, in fact, that TZDs are very effective in preventing cardiovascular disease in this group of people. So it's a big study. Drs. Kernan and Inzucci, Dr. Inzucci from Yale, almost 4,000 non-diabetic patients. And these people had a recent ischemic stroke or transient ischemic attack. Their age is, not surprising, a little bit on the older side, 64. They're modestly obese, and they are hyperinsulinemic. And they're, in order to get into this study, you had to be insulin resistant. The HOMA index, which takes into account the fasting glucose and the fasting insulin, was 4.7. You had to have a HOMA IR, HOMA insulin resistance index, greater than 3. So these people were insulin resistant, but they were not diabetic, okay? And you can see here, mean A1C is 5.8. Half of these people didn't even fall into the pre-diabetic range. So what happened? On the y-axis, the cumulative probability of event-free survival. And what was the event? Recurrent stroke or myocardial infarction. You see here in yellow, the PO, in orange, the PO curve falls above the yellow curve. So there was a 24% reduction. Hazard ratio is 0.76, a 24% reduction in recurrent myocardial infarction in stroke. And clearly, this can't be due to an improvement in glycemic control, because these people had an A1C of 5.8 to start with. And I can tell you that in this study, we just have reanalyzed the data, and the people who got pioglitazone at 45 milligrams benefited similarly to the people who got a dose of 15 or 30 milligrams. So you can see this beneficial effect in cardiovascular protection at lower doses of pioglitazone as well. Now, in the IRIS study, remember I told you the A1C is 5.8. So half of these people weren't even in the pre-diabetic range. Pioglitazone decreased the incidence of diabetes by 72%. You can see here hazard ratio is 0.28, very highly statistically significant. So in this pre-diabetic, as well as what I call pre-diabetic range, pioglitazone effectively reduced recurrent cardiovascular events and progression to type 2 diabetes. Now, this is Dr. Zinman's study from Canada in Native Canadians who had IGT. In this study, he used rosiglitazone, which no longer is available in the United States, at a low dose. The maximum dose is 8 milligrams, plus metformin, 1,000 milligrams, again, half the dose of metformin. And then he followed the people up for 3.9 years. And you can see here a very similar result to what I showed you in the ACT NOW study. So placebo group converting to diabetes at a very high rate in yellow, the rosy metformin group at a very low rate, hazard ratio is 0.31, 69% decrease. And I would say probably the most effective therapy is going to be a low dose pioglitazone plus low dose metformin. In the ACT NOW study, we of course use just pioglitazone alone. Now, what about incretin hormones? They are very good at promoting weight loss, and they have a dramatic effect to improve beta cell function. So this is from the SCALE study. This is the LaRue study. These are in obese pre-diabetic individuals treated with either placebo or with liraglutide. Placebo in yellow, liraglutide in orange. You can see hazard ratio 0.21. That is a very dramatic reduction of almost 80%, very similar to what you would see with the TZD, with a p-value less than 0.001. I would say the major drawback of the GLP-1 receptor agonist, so many people don't like to give injections, and the cost is significant. But these drugs are very, very good at promoting weight loss. They generally, the weight loss is about 7% of body weight over the first year of therapy, and they have, independent of the weight loss, which will improve insulin sensitivity. They have very powerful effects to improve beta cell function. So the GLP-1 receptor agonists are excellent drugs for preventing prediabetes from going to diabetes. So in summary, at least at this point, we know that diet and exercise work if people will stick with it and lose weight. We know that metformin works, but in my opinion, it's relatively weak compared to the thiazolidinediones and the GLP-1 receptor agonist. We also know that the alpha glucosidase inhibitors are effective. And in fact, in a recent study from China in treating diabetics, Archibos was shown to be as effective as metformin, but that is in countries where there's a very high carbohydrate intake in the diet. So can you now take these lessons that we've learned from pathophysiology and the studies with TZDs in GLP-1 receptor agonist and translate this to real life situation? So I have two very good associates in California, Dr. Armarto, who's an endocrinologist, and Dr. Ruby, who's a primary care doctor, who have a big interest in diabetes and prediabetes. And they get many patients referred to them for assessment of prediabetes. 1,769, you can see a lot of these people really didn't fit the criteria of prediabetes. So they enlisted 747 who were evaluated in more strict terms, and 422 actually had pre-diabetes. And they were then going to be stratified into three groups. 141 got pioglitazone and metformin. And in a moment, I'm going to tell you how we assign them to this therapy. 81 got assigned to triple therapy with pioglitazone, metformin, and a GLP-1 receptor agonist. And then those high-risk people who didn't want pharmacologic therapy were assigned to lifestyle modification, okay? So we had three measurements. Everybody had an OGTT. So we know from other studies that we've carried out that people have a 2-hour value greater than 155. In fact, this is the best predictor who's going to develop diabetes. So this was a measurement of their glycemic risk. We, from the Matsuda index during the OGTT, had an index of insulin sensitivity, and then we had an index of insulin secretion during the OGTT. And then based on these three parameters, we developed some cut points that indicated they had mild, moderate, or severe defects, okay? And there's actually an equation online that tells you how to do this. Now, if you had a severe defect in two of these three, or a severe defect in one of the three, plus one moderate defect, you got the triple therapy, pioglitazone, metformin, and xanthide. If you were at low risk, meaning based on the glycemic response, insulin sensitivity, and insulin secretion, all being mild, you were in the low risk category. In the intermediate group, all others got double therapy with pioglitazone or metformin. Low risk got assigned to lifestyle. Now, what happened? You can see here pretty dramatic results. The people in lifestyle, 60% of them converted over a 100-month follow-up period. The pioglitazone and metformin, about 20%, and in the pio metformin exenatide group, you can see less than 5%. Now, I want to come back to this pio metformin exenatide group in a second. So if you look at the hazard ratio of metformin pioglitazone versus lifestyle, 0.29. If you look at the triple therapy versus lifestyle, 0.12. Now, this 0.12 is misleading because, in fact, in the triple therapy group, no people develop diabetes. But the problem is it's very difficult to do an analysis if you have an n equals 0. So in the publication, we assume that one person developed diabetes over the lifetime of follow-up. So now in the lifestyle group, you see a very high annual conversion rate of prediabetes to diabetes. Proglitazone decreases this by about 60%, and the triple therapy by 0%. And then people who are at low risk based on their glucose value or the insulin sensitivity or the beta cell function, not surprisingly, they had a very low risk of developing diabetes. But this triple therapy is very, very impressive. Over 100 months, over 100 weeks, you can see that 0 people converted. So now the question comes up, I'm always asked, why don't we just wait till the person develops diabetes to institute metformin therapy? Or I would say even better to start agents that work even better than metformin, meaning TZDs, pioglitazone, and GLP-1 receptor agonist. Okay. Now I already told you if you're 6.4 A1C, you're pre-diabetic. If you're 6.5, you're diabetes. You know, well, what's the difference? Okay. Now, here's the big problem. This is the gold standard index of beta cell function. During the OGTT, increment in insulin per increment in glucose, all factored by how insulin resistant you are. So this is from 2 big studies we carried out in San Antonio. And you can see here within the NGT group, according to the American Diabetes Association, I do an oral glucose tolerance test, and your total glucose is less than 140, you have normal glucose tolerance. Well, we divided the people into 3 groups. Those people who had a 2-hour glucose less than 100. This is as good as your glucose tolerance is going to be. People whose 2-hour glucose was 100 to 120, 120 to 140. Well, within the quote group of people who had normal glucose tolerance, you can see these people already lost 60 to 70% of their beta cell function. And I'm not going to show you the insulin resistant data, but they also were significantly insulin resistant. Let's look at the people who have IGT, impaired glucose tolerance. You can see I divide them into 3 groups, 140 to 160, 160 to 180, 180 to 120. The people here in the upper tertile of IGT, they've lost over 80 to 90% of their beta cell function, and they're already maximally insulin resistant. They have diabetes. Pre-diabetes, a very bad term. And you can see now if I put the diabetics up here, it doesn't take, much loss more of beta cell function to go from a 2-hour glucose of 180 to a 2-hour glucose about 300. So the point here is that at the stage of IGT, particularly in the upper tertile of IGT, you've lost 80% of your beta cell function and you're maximally insulin resistant. So why do you want to wait to start the pharmacologic therapy? Now, here's the bigger problem, okay? What's happening to beta cell mass? So this is a study by Dr. Peter Butler. These are people who succumbed, died in a automobile accident or for other reasons. And then Dr. Butler had a study approved by his IRB and I think funded by the NIH to remove the pancreas and to measure the beta cell volume. So he couldn't wake these people up, obviously, and do an OGTT, but he could measure the fasting glucose in these people. So the NGT group are shown in yellow. Let's look at the people with IFG. So in the top, you see the fasting glucose is elevated, but in the people who have impaired fasting glucose, they already have lost some 40% of their beta cell mass. And if you now look at the people with type 2 diabetes in orange, they've lost even more of their beta cell mass. So the point here is if you look at the bottom, if you look at beta cell volume, as you go from NGT to impaired fasting glucose or prediabetes to diabetes, there's a progressive loss of beta cell mass. So to me, you need to be starting the therapy at the pre-diabetic stage to not only improve beta cell function, but more importantly, to prevent this loss of beta cell mass. And physicians are very bad at instituting therapies. So this is a study from Kaiser Permanente where they have very good IT program. And so when people come for their lab test, the A1C is recorded in the chart. And then if a change is made in their medication, that is also recorded in the chart. So you can go back and look what happened to patients, okay? So these are now people who who are diagnosed as diabetes, and we're going to look and see how long it takes the doctor to make a change when the A1C you can see is greater than 8. Not when the A1C is greater than 7. So patient comes in, A1C is greater than 8. Okay, if they're on diet and exercise therapy, it takes almost 9 months for the doc to do something, like add metformin. If you're on metformin, it takes 15 months for the doc to do something, meaning increase the dose of metformin or add a sulfonylurea. If you're on a sulfonylurea, it takes 20 months for the doc to do something. And if you're on metformin and an SU, it takes 26 months. So the more therapy they're on, and particularly the orange bar, docs don't want to start insulin. But this is what's called physician inertia. And this is actually one of the better studies that's in the literature. So docs, even though they know you have diabetes and you're poorly controlled, they don't start the drug. So I'm really reluctant to say, okay, let's just wait till the person crosses that A1C line and now has a diagnosis of diabetes. So this is the last slide. This is this young lady looking at the doctors saying, hey, doc, you know that low calorie, the weight loss diet that you put me on many years ago, all it did was give me diabetes, high blood pressure, and heart disease. I don't think this is such a great therapy. Well, this is my last slide. Hopefully you all who are listening in found this to be informative, and you'll be able to take home some of these messages and apply them in your practice. But stay tuned. We have a great program with 2 more speakers coming up.
Thank you, sir. Thank you, Dr. Rao-Tafauza. This was just amazing. We have more than 1,000 delegates logged in who are absolutely fascinated, and we have tons and tons of questions coming in. So it's going to be a very exciting panel discussion. We hope you're going to stay with us, sir, till the panel discussion.
I'll be with you.
Yes, thank you so much. We move on to our next wonderful speaker, and none other than Professor Dr. Anup Mishra, sir. He will be taking us through prediabetes in Asian Indians and the role of metformin and vitamin D. Over to you, sir.
Just give me a minute to share my slides. Just
Please.
give me a minute on this.
Yes.
Okay, can you see my slide now?
Yes, sir. Perfect.
Okay, thank you. First of all, let me thank everybody in IDEC. I'm really grateful to all of you for giving me this opportunity to speak alongside Dr. DiFranzo. And my job is so much simpler because he has spoken at such length on the diabetes prevention program and also various other ways that we can prevent diabetes from pre-diabetes. So what I'll do is I'll be brief, number one, and number two, I will just go through the prevention slide and metformin in a jiffy because Dr. Ramchandran will be speaking a lot about it in Indian context. And I will just speak a couple of things about prediabetes, which may be of interest to most of the readers. Now, we all know about this, so I don't have to really go into it. But still, as Dr. DiFranzo said, that impaired fasting glucose and impaired glucose tolerance may be 2 different entities, but together they constitute prediabetes, and we know what are the limits of prediabetes, when should we diagnose it, based on the fasting blood glucose, oral glucose tolerance test, and HbA1c. Now, prediabetes is prevalent in Indian population and is pathological. This is 2 graphs which have been taken from one of our articles which have been published recently, a meta-analysis of 1.7 million adults, a pooled systemic review and meta-analysis of Indian population. Of course, it includes a lot of data from Dr. Ramchandran, Dr. Mohan's study. And you can see it includes data from 1972 to 2019, a most updated meta-analysis. You can see how diabetes is going up, both in the urban and rural area. This is the rural graph here. But more importantly, if you go towards pre-diabetes, it is fast rising, but not only fast rising, it is the rural graph which is surpassing the urban graph. And of course, Dr. Ramchandran is the master of all these things. I leave the explanation to him. But this is a little disturbing trend that has been seen and needs to be tackled on immediate basis. We have known now from Dr. Di Fronzo's slide that risk of cardiovascular disease is elevated in impaired glucose tolerance. And this is a very old study, a very standard slide, which shows how stepwise the cardiovascular risk increases, and by the time we have IGT, the cardiovascular risk is already high. But what we don't know, what is happening in the Indian population? And to tackle this point, whether Indian population has some problems related to prediabetes, one of the things that we chose was leukocyte telomere length. Now, this is the shorter the length, the worse of it is. It shows that the person may have shorter longevity. So it's implication for lifespan. This is accepted for publication in BMJ Open. 797 pre-diabetic women, both obese and non-obese, and we had done a quantitative estimation of LTL, and they were separated into quartiles, groups of the body fat, BMI, and subcutaneous fat, and we looked into what happens there. Now, if you look at this is very interesting graph. These are the various skin fold thickness, biceps, triceps, subscapular, suprailiacs, and a pool of central skin fold. This is the pool of central skin fold, pool of peripheral skin fold, and this is the total skin fold. Skin fold denote subcutaneous fat. And we have been saying for a long time that Indian population has thicker subcutaneous fat, especially in the truncal area, is denoted by subscapular and suprailiac skin fold. You look at this. As far as the quartiles of the LTL is concerned, the thicker the skin fold, the shorter is the LTL. And this does not happen as far as peripheral skin folds are concerned. So something is happening here. The thicker the subcutaneous tissue, the shorter the leukocyte telomere length in patients with prediabetes. And remember, these were women with prediabetes. And when we looked at other parameters, for example, apart from central skin fold and total skin fold, body mass index and body fat, we found independent correlation of LTL with central skin fold, total skin fold, BMI, and body fat. So a truncal obesity and obesity, if present in patients with prediabetes, are correlated with a shorter LTL. The length of the telomere is shorter, denoting possibly shorter lifespan. Now, there are a couple of things, a couple of features that I want to tell you about the prevention besides what has been told by Dr. Defonso, and Dr. Defonso has spoken about this. The lifestyle in the initial DPP-4 study led to greatest reduction in cumulative incidence of diabetes, followed by metformin. Indian data will be presented by Dr. Ramachandran. Well, when we extend this DPP-4 study to DPP-O study over a 15 years time, if you look at this, the metformin curve is coming closer to lifestyle. So the benefits of lifestyle are maintained, but possibly those who had metformin are now inching closer to the curve of benefit of lifestyle. And this was published in Lancet in September 2015, and this is my editorial written by me, The Prevention of Diabetes, More Answers, There Are More Questions. This I'll leave it to Dr. Ramachandran to cover. Indian Diabetes Prevention Program. Another thing I want to emphasize is that if you look at the cardiovascular parameter, one of the parameters that this study has taken is coronary artery calcium. In 2029 participants of DPP and DPPOs, it was done after 14 years of follow-up, and it showed that those who are on metformin group actually had less severity of coronary artery calcium, less presence of coronary artery calcium. But as far as lifestyle group is concerned, there was no difference between placebo and lifestyle. So metformin is doing something here, something as far as heart is concerned, as indicated by coronary artery calcium. So that way it is scoring a little bit more than lifestyle over a period of 14 years. Now, Indian population. We now know a little bit more about Indian population over the last 10 to 15 years, thanks to studies by several of groups in India and abroad. One person who has put it all together is Naveed Sattar. And in Lancet 2015, he's put this beautiful graph explaining how early is rise of blood glucose in Indian population. And if you see here, this is rise so fast from pre-diabetes to diabetes. Almost 10 years before anything happening to the white population. So whether it's a pre-diabetes or diabetes, both are 10 years earlier. So progression to diabetes from pre-diabetes is 12 to 18% per year. And once we apply the lifestyle factor, it is reduced by 30%. And look at the data from the Western population. Progression to diabetes is only 5 to 11% versus 12 to 18%, and reduced by more than 50% with lifestyle intervention. So we are having pre-diabetes earlier, 10 years earlier, and diabetes 10 years earlier. Conversion rate from pre-diabetes to diabetes is faster. And if we apply the diet and lifestyle factors to a particular person, the chances of getting back into normal glucose regulation is smaller than the Western population. This is how, in one diagram, we know what is happening as far as pre-diabetes and diabetes in Indian population is concerned. Another factor is age. Now, this is a slide taken from DPP trial. And 3 age categories. And if you look at the more than 60 years of age and lifestyle, how lifestyle is acting versus metformin and placebo, very interestingly, lifestyle is actually better than metformin in more than 60 years of age, and the metformin actually not acting too much. So in more than 60 years of age, it's best to try lifestyle and less of metformin versus the younger ages. Non-obese individuals are likely to be low insulin secretors, and they may have problem in reverting back from pre-diabetes to normal glucose regulation. We know that Indians develop diabetes at a very low BMI. Look at this BMI and Indian population developing diabetes right here versus several other populations. So even not only non-obese category, even in lean population, we see a lot of diabetes. And this has been corroborated. There's a 2007 paper corroborated number of times, including a recent paper around 15 days back, which says the same thing. And both men and in women. We also know that in these non-obese people, normal BMI or low BMI, the beta cell mass may be less. And this has been shown in a autopsy study, which is non-diabetic people, how much is the beta cell mass, and here is the lean people, non-diabetic, and beta cell mass is much less versus obese people. So beta cell mass may be less in these lean people, and they may be low secretors, and hence there may be problem in reversion back to the normal glucose regulation. Early remission of pre-diabetes by application of lifestyle factors on that. This has been seen very well as far as DPP study is concerned, and DPPO's follow-up study. If we have a person with pre-diabetes today and we apply a very intensive lifestyle measures and he reverts back to normal glucose regulation within next 3 to 6 months, his chances of not going into diabetes is much less than a person who doesn't revert back. And this has been shown in this particular graph. They never reached normal glucose regulation in DPP, so they're going on to diabetes. They have higher chances versus at least once in DPP. So first 4 years, you reach normal glucose regulation, your chance of going into diabetes is much less. Liver as a center of metabolism and both predicts diabetes and causes problem in reverting back from pre-diabetes to diabetes to normal glucose regulation. Now, presence of NFLD alone predicts diabetes, and this has been shown by us. Just diagrammatic representation of a normal liver with a normal liver span, and this is the large liver with large liver span. And liver span can be measured by ultrasound, and a liver span more than 15.6 portends 4 times risk of developing diabetes if you're doing ultrasound. So large liver itself predicts development of diabetes, but more importantly, if there is a liver which is fatty liver, non-alcoholic fatty liver disease, plus there is documented insulin resistance, it is a high risk phenotype. And a reversion after lifestyle intervention is much less. Fat loss is much less as compared to low risk phenotype, which are all other traits. Postprandial glucose decrease is much less. A reversion to normal glucose regulation is only 31% versus 67% in the lower risk phenotype. And such phenotypes have been defined further. And these are 6 types of phenotype, like the phenotypic definitions of diabetes, which have been also published. Here, these phenotypes have been divided by the presence of obesity, fat distribution, insulin sensitivity, insulin secretion, glycemia, etc. And I would like you to pay attention to these 3, where though overweight, they have less insulin sensitivity, low insulin secretion, and so they may develop diabetes. So this is high chances of developing diabetes. Phenotype number 5, which I have already shown you, higher insulin resistance and fatty liver, low insulin sensitivity, markedly low, very high insulin resistance, low insulin secretion, and they also develop pre-diabetes and then go on to develop diabetes. And then high visceral fat and the renal sinus fat. You see here, renal sinus fat. Now, they don't only develop diabetes, but they have high chances of developing nephropathy and high mortality. So these are the various phenotypes which have been made based on the white population. We don't know about such thing as far as the Indian population is concerned. So the black one indicates high mortality as well as the nephropathy. Gestational diabetes is another problematic phenotype because after this, their conversion to diabetes is very fast, and this is a systematic review which shows that after gestational diabetes, there is a very steep increase in the development of diabetes first 5 years, and then subsequently there is a plateau. And an Indian study shows that within 20 months after delivery, dysglycemia was found in 57%, diabetes in 10.5%, and pre-diabetes in 47.2%. So this has to be kept in mind once one is treating patient with gestational diabetes. And finally, this is my favorite topic, and I have put query there because things have not settled. Low vitamin D. We know about low vitamin D and its correlation with metabolic syndrome, abdominal obesity, and hyperglycemia. This is published several years back, which shows that if the vitamin D is low, there is high chances of metabolic syndrome, abdominal obesity, hyperglycemia. And then subsequently, we have published a lot vitamin D in obesity, and we showed that subcutaneous abdominal fat and intra-abdominal fat, it is correlated with the low levels of vitamin D. And then subsequently also the PTH and low vitamin D was correlated with the non-alcoholic fatty liver disease. So these are our earlier studies with vitamin D and obesity and non-alcoholic fatty liver disease. Subsequently, number of people have published association study, means low vitamin D, whether it is associated with either pre-diabetes, high glucose, or diabetes. And you can see heterogeneity in studies, different ages, different types of diagnosis, different numbers, different endpoints. But association studies were largely positive except one or two. Then we published in pre-diabetes the association of low vitamin D with higher fasting blood glucose levels within the ambit of impaired fasting glucose. This was published in BMJ Open. Then we reviewed all the randomized control trials, and these were done in countries other than India. And you see very few trials actually showed any association between vitamin D and diabetes. But again, heterogeneity of studies. This is the largest study on the top, but they were different people, some with the vitamin D deficiency, some without vitamin D deficiency. So that way, these are heterogeneous studies, not very well controlled sometimes, and sometimes very small number of people and small period. This was the meta-analysis. 2017, there was a modest reduction in A1C compared to placebo, but no effect on fasting blood glucose. Overall, vitamin D supplementation. But in the studies achieving repletion of vitamin D deficiency, there was greater mean reduction of A1C. And so there are two types of study where all patients were taken regardless of vitamin D deficiency, and then vitamin D deficient people, they showed further reduction. And this is the meta-analysis. And then second meta-analysis also showed that although A1C level decreased and not fasting blood glucose, but further decreased in A1C and fasting blood glucose among patients with vitamin D deficiency. And so we reviewed Indian studies, which are randomized controlled trials. And surprisingly, most of the Indian studies showed there's some effect on the fasting blood glucose. And the longest randomized controlled trial has been conducted by us. This was published in scientific reports. 121 women with these were having pre-diabetes allocated to vitamin D and placebo intervention for 78 weeks. Now, if you see the classification of normal glucose tolerance, pre-diabetes, and diabetes change as far as fasting blood glucose is concerned after the intervention. Now, this is the intervention. This is the intervention. So, normal glucose tolerance increased, the pre-diabetes decreased. And same for if we take 2 hours post oral glucose load, where the normal glucose tolerance increased and impaired glucose tolerance, as far as that is concerned, they decreased. Also, additional feature was decrease in the subcutaneous fat. Look at this, week 0, 52, and 78 weeks, the subcutaneous adipose tissue as measured by skin fold decrease in the intervention group, and not so much as far as the subscapular skin fold and suprascapular skin fold. So this is my final slide summarizing my presentation and also taking some leaf out of Dr. DiFranzo's and some leaf out of Dr. Ramchandran's talk, which is coming. Prediabetes is an important intermediate condition which identifies those at risk for diabetes and coronary artery disease. It is common in Asian Indians. Conversion to diabetes is faster than white. It's possible that prediabetes in presence of truncal obesity decreases lifespan in Indians. Metformin is useful for management of prediabetes, and there in certain segment of these pre-diabetic population, it is more useful. And it may also have some effect on coronary artery calcium. Identification of different phenotypes which may impede conversion of the prediabetes to NGR is important for application of aggressive lifestyle and medical therapy. Among these important are age, quick remission with lifestyle measures early on, and presence of non-alcoholic fatty liver disease and insulin-resistant phenotype. And more research on vitamin D is needed in the context of prediabetes in Asian Indian population. So thanks, Sanjay. Thanks, Nita, everybody, for giving me this opportunity and letting me present our own data in this conference.
Thank you, sir. Thank you so much. And this was a step forward. And now we have so much to talk about that I think we will have very little time in the panel discussion. Thank you so much. Without waiting, I will go to the next topic and our next speaker, Dr. A. Ramachandran, sir. Sir is going to take us through the pro-inflammatory biomarkers in prediabetes and the role of metformin. Over to you, sir. Sir, you're on.
Okay.
It's visible, sir.
Can you see my slide?
Yes, sir. Perfect.
Yes, sir.
Yes, sir.
Okay, thank you. So thank you, the IDEC group, and especially Sanjay for the kind invitation today. And I'm very happy that I could join the light group of Anup and Raj today. Thank you both for your excellent talks. So I thought I will be talking about a little differently today, because we have been talking on primary prevention trials, which have been done in many countries. But I think today we are on an important milestone, because the DCGI in India has approved metformin for the use in people with pre-diabetes to prevent diabetes. I think that's good news. So in the light of this enrollment and this approval, I thought I must talk about metformin and its role in the management of prediabetes or prevention of diabetes. I'm also going to touch upon some of the new data which we have published recently on the inflammatory markers. In fact, I feel that prediabetes and diabetes are inflammatory diseases, and I'm going to show you some proof for that and how metformin can help in that context. Okay, these are the prevention trials, and Ralph has already alluded to this. The first study was from China, and then came the Finnish trial, and then came the DPP. For the first time, we used metformin as one of the strategies, and then we came the IDPP1, in which we used metformin, and then the DCLIP study also used metformin. There's another study from Japan which also used metformin. ACNO has been already described by Raj in his talk. So these are the main trials which use metformin in the primary prevention trials. The DPP trial, which showed 38% reduction. The Indian Diabetes Prevention Program, which randomized 531 people for 3 years and showed almost 26% reduction with lifestyle modification, but 28% reduction with metformin. So 26 and 28, so there is not a big difference between all of them, almost about 28 to 30%. There was no added effect of metformin. I'll just talk about that in a moment. The DCLIP study was another Indian study in which metformin was introduced when lifestyle modification was not giving a response. And they found that there was a 32% relative risk reduction, which is exactly similar to what we found in the IDPP. And it was also interesting that they found that when in the isolated IFG, the relative risk reduction was only 12% compared to IGT. So somebody asked the question whether metformin is more effective in IGT. I think perhaps prevention strategies are more effective in IGT, at least in the Indian context. There are other studies. Again, in China, they used 750 milligrams of metformin with 88% relative risk reduction. The Cano study, which Ralph already referred to, done by Bernie Zinman, showed a combination of metformin plus TCD had a 66% relative risk reduction, pretty high. The only study which did not show an effectiveness or efficacy of metformin in the prevention of diabetes was the IDEC trial, which is done by Holman's group from Oxford. And that is surprisingly, they did not find an effect with metformin or with the carbos. So to come back to the Indian Diabetes Prevention Program, for those people who have not read this, we actually randomized 531 subjects with impaired glucose tolerance into 4 arms. One is standard therapy or no intervention, lifestyle modification, metformin, and a 4th arm of lifestyle modification plus metformin. Incidentally, I should thank the US Vitamins here. Farida is here with us. It is one company which actually supported the IDPP back in 2005. Thank you, US Vitamins. So this is the results of the IDPP showing you the cumulative incidence of diabetes in 3 years' time. There's a median period of 2.5 years. The cumulative incidence in the control group was 55%, and with lifestyle modification 39.3. With metformin, the cumulative incidence was 40.5, much reduction, and a combination 39.5. In other words, you can see that the incidence of diabetes in people with impaired glucose tolerance, or in other words, the conversion of pre-diabetes to diabetes in the Indian population is much higher than the white population or the American population. So we have found that a faster conversion, not only in the Asian population, but also in the Chinese population. So the incidence of diabetes among people with impaired glucose tolerance is almost 2 times or 2-fold higher in the Indian population compared to the white population. So the conversion to diabetes was significantly reduced by lifestyle modification by 28.5%, metformin 26.4%, and the combination 28.2%. So I think 2 strategies did not have an added benefit. The number needed to treat was pretty similar to what was shown in the DPP trial with lifestyle modification, 6.4 with lifestyle modification, 6.9 with metformin, and 6.5. In other words, even though relative risk reduction was not that great as what is shown in the DPP, the number needed to treat was pretty powerful, and I think it has been very cost effective. This is the comparison between actually the IDPP and the DPP along with the DVFS. And the most important thing to see here is that based the BMI of the people with impaired glucose tolerance in India was only 25.7 compared to 34 in the United States and 31 in Finland. So in other words, obesity was not actually prevalent in these people. These are mostly non-obese people to the international standards. The second point, that we used only 500 milligrams of metformin per day, while in DPP they used 850 milligrams PD, which is 1,700 milligrams. The lifestyle modification was very intensive, both in the DPP and the DFS. And as Ralph has commented, it is very difficult to actually continue to do intensive lifestyle modification for a lifetime to prevent diabetes. However, we used a moderate intervention, and of course, we still got the results, which is a significant reduction in the conversion rate. And we also found that the weight loss was not significant compared to what was seen. So in the DPP and the DFS trial, what they did was they took overweight people or obese people, made them lose weight and prevented diabetes. I think for us, that this is people with non-obese people itself, we were able to prevent diabetes with even a moderate lifestyle modification. The other study which is to be commended is the Indian SMS study, in which we used mobile phones through their short messages to change the behavior of people to see whether we can prevent diabetes. This was actually funded by the United Kingdom Education and Research Initiative, and it was done in collaboration with the Imperial College in London. This was the randomization design. We had about 407 people with impaired glucose tolerance, and in each group there are 202 people, 1:1 randomization. The control group had standard advice, but in the intervention group, there was standard care plus motivational text messages sent with a mobile phone, which is pretty economical, cheap, and cost effective. And the follow-up was for only 2 years. Mind you, the IDPP was for 3 years, but this was only for 2 years. But surprisingly, we got a very, very significant result, a 36% validity risk reduction in 2 years' time in those patients who received the SMS. In other words, it looked as if that sending messages on mobile phones on behavioral modification did work and prevent diabetes in these individuals. This shows you the absolute risk reduction, 9%, relative risk reduction was 36%, and the number needed to treat was 11%. As you can see, the absolute incidence was 27% of the control group, 18% of the intervention group. So I think the intervention significantly reduced the incidence in diabetes in 2 years' time, and I think, again, it is a very powerful tool. Now, one of the things that we looked at was that we found that early improvement can actually predict the results. As you can see, within 6 months, there are a number of people who actually reversed to normal glucose tolerance. And what we found was that those people who had normal glucose tolerance, within 6 months of the follow-up, there was only 6.3% incidence of diabetes, while those who continue to have IGT had a 24% incidence of diabetes. In other words, the reversal of diabetes, if obtained or ascertained faster during the trial, then you can further make it a more powerful tool to decrease the incidence of diabetes. So there was a 75% relative risk reduction if the normoglycemia was achieved within 6 months when the trial was started. This is the DCLIP study, which I told you. In fact, this is a little rare type of design in which what they did was they used lifestyle modification for everybody, and those who did not respond within 6 months were given metformin 500 milligram 2 times. And in fact, 60 to 70% of the individuals needed metformin, and in the final outcome, those patients, people with the IGT had a 31% reduction, those with IFG plus IGT had 36% reduction, relative risk reduction, and those with isolated IFG had only 12% relative risk reduction. In other words, it looks as if metformin reduces the risk of diabetes much better and more significant in people who have impaired glucose tolerance compared to those who have only isolated IFG. So now the mechanism of reduction. Now, how does metformin work, or how does lifestyle modification work? I think Raf alluded to this mechanisms in his talk, but what we did was, this is the insulin secretion or the delta Ig ratio in those patients who developed diabetes during the 3-year period in the IDPP. As you can see, there was a significant deterioration in the beta cell function, and there was also an increase in the insulin resistance by measured by HOMA-IR. On the other hand, if you look at those who prevented diabetes, what happened was that it significantly reduced the insulin resistance. In fact, improvement in insulin resistance and also maintenance of the same beta cell function has improved or facilitated the prevention of diabetes. So that's the mechanism. This is actually published in Diabetes Care soon after we published the IDPB results. The other point here is that when you look at it, that probably we have not improved the insulin secretion. However, the best measure would be to take a product of these two together, because the insulin secretion is relative to the insulin resistance. And therefore, we have looked at in our new study a better measurement of beta cell function called the disposition index. It is called that is adaptation of insulin secretion into prevailing insulin sensitivity is a tightly regulated mechanism, and therefore deterioration of both functions is associated with the development. Product for insulin secretion and insulin sensitivity is a constant, which is a better index of the beta cell improvement or secretion, and this is called oral disposition index. And this is a better and more accurate measurement of beta cell secretion, compensate for chronic insulin resistance. And this is a curve, or the hyperbolic curve, actually propounded by Steve Kahn. And what you find here is that as the beta cell function, as the insulin sensitivity decreases, there's an increase in the beta cell function, which is compensatory. And that is in the normoglycemic individuals. On the other hand, if there's a drop of this curve down into the left, and then what you find is that your insulin resistance is increased, there is no compensatory improvement in beta cell function, and that is why you get dysglycemia or diabetes. So based on this, we do the disposition index, and what we found was that in those subjects in whom we prevented diabetes, the oral disposition index, or in other words, the insulin secretion capacity, improved significantly if you compare to those people who developed diabetes. And this is a better index of finding out how mechanistically we have prevented diabetes in those patients in whom the strategies really worked to reduce the incidence of diabetes. This is called the oral disposition index, which gives you a better index of the beta cell function in association with the prevailing insulin sensitivity. Now I come to more interesting fact for doctors, and that is called biomarkers in diabetes and in pre-diabetes. I think this is a lot of interest in this lately. What is a biomarker? All of you know that it is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or even pharmacological responses to therapeutic intervention. The FDA definition is that any measurable diagnostic indicator that is used to assess the risk or presence of disease. In other words, biomarkers are not only predictive of diseases, but are also involved in the pathogenesis, and therefore modifying them has a potency to change the course or onset of diseases such as diabetes and even cancer. So what you find is that when people with pre-diabetes are taken, they can become normal or become diabetic. There are multiple mechanisms by which pre-diabetes become diabetic. Of course, there's a beta cell secretory defect and increasing insulin resistance. But other than that, I'm sure there are other markers called pro-inflammatory cytokines or adipokines, which can increase incidence or conversion of pre-diabetes to diabetes, as well as also be responsible for cardiovascular events. And I'm going to show you data from our own studies to show you how the adipokines are an important measurements in the pathogenesis of diabetes. So biomarkers in the as a pathogenetic mechanism in diabetes is diabetes seems to be an inflammatory disorder because we find that most of the adipokines are high in diabetes. And biomarkers would probably predict diabetes in those who are non-diabetics. So therefore, these biomarkers may be added to conventional risk variables to improve the power of association or prediction of diabetes. Because we know that when you do a follow-up of people with pre-diabetes, even without any strategy, some of them can reverse to normal. But if they also have a pro-inflammatory high concentration levels, then the risk of getting diabetes increases. Therefore, improvement of biomarkers or treatment biomarkers or inflammatory adipokines could influence prevention of diabetes. Now, how do we abate the inflammatory process in a pre-diabetic stage? Can interventions of prevention do the trick? So in our study, we have looked at several adipokines or inflammatory markers, which include adiponectin, retinal binding protein, the liver enzymes. I think Dr. Anup has just mentioned about fatty liver disease and the risk of diabetes, interleukin-6, leptin, and a couple of new ones called visfatin and fetuin A. Early in 2003, we published the first data. This is one of the first data on adiponectin as one of the association with adiponectin and diabetes. Adiponectin is a hormone produced solely by the adipocytes and is a regulator of glucose and energy homeostasis. So therefore, low adiponectin is associated with low insulin sensitivity, and it participates in the etiopathogenesis of type 2 diabetes. So in the Indian Diabetes Prevention Program, we published this data to show that those subjects who had a low level of adiponectin at baseline had highest risk of diabetes during the follow-up, because low levels of adiponectin actually reduces insulin sensitivity. So what you see here is the incidence of diabetes in the first, second, and third tertiles of adiponectin at baseline, and you find those in the first tertile has the highest incidence of diabetes. In fact, many papers came out after this publication from our own study. We had repeated adiponectin, but also looked at interleukin-6 and leptin for prediction of diabetes. Now, adiponectin improves peripheral insulin sensitivity. Interleukin-6, on the other hand, alters insulin signaling in hepatocytes, adipocytes, and impaired energy regulation in the central nervous system. Leptin, as you all know, is related to insulin resistance. So what we found was that a repeat study of the adiponectin was negatively related to incidence of diabetes. In other words, low adiponectin predicts diabetes, and high interleukin-6 predicts diabetes, which is also a pro-inflammatory adipokine. Leptin was not associated with the incidence of diabetes. We did another new one called the retinal binding protein. And what is this? Retinal binding protein is a protein that belongs to the lipocalin family. It was initially known as a specific carrier for the delivery of retinol in circulation, and that is why the name came. But it is secreted mainly by hepatocytes. So therefore, it can be called as a hepatokine, not just an adipokine. And 20% is secreted by the adipose tissue. So it is actually the misnomer. It is nothing to do with the retina or the retinol, and contributes to systemic insulin resistance and impaired glucose regulation. And we did this study in which we found the baseline retinal binding protein was independently associated with diabetes after adjusting for all the metabolic variables. Model 2 adjusted for age, BMI, waist circumference. Model 3, along with that, we also adjusted that with the GGT and HOMA-IR in the model 2. So there was a significantly high odds ratio for incidence of diabetes. Now, Anup just talked about NFLD and incidence of diabetes. From the prevention study, we looked at the liver enzymes at baseline to study the association at baseline GGT and ALT with incident diabetes. And incidentally, we found that GGT, median above, has associated with incidence of diabetes with a hazard ratio of 2.18. And when you adjust further, it goes to 1.78. So this shows that liver plays a role in the pathophysiology of diabetes. Whether correction of this metabolic abnormality could prevent onset of diabetes is an important question. The last one is published in 2021 October, only a few months ago. And this is looking at hepatokines and also more important adipokines. The two important adipokines that we study, one is called the visfatin, which is actually produced by the visceral tissue and is called a visceral adipokine. The other one is fetuvin A. Visfatin is regulated by hormones and cytokines influencing glucose homeostasis, correlated with markers of obesity, parallel increase with insulin and in hyperglycemic state. Fetuvin A, on the other hand, is mostly produced by hepatic tissue. So it's called a hepatokine. It has been shown to be elevated in obesity and in type 2 diabetes. So now our question is whether higher levels of these adipokines during the pre-diabetic stage can predict diabetes. And that is exactly what we have shown here. What is shown here is that in the tertile 3 of visfatin, there was a significantly high incidence of diabetes, 54.2 compared to only 12 point in those, or only 13.9 in those with tertile 1. So higher levels of visfatin predicted diabetes. We also found that higher levels of fetuvin also predicted diabetes. In the tertile 3, there is a 55.6% incidence of diabetes compared to only 12 point in the tertile 1. We all find that if you combine these two together, visfatin plus fetuvin, this combination of two biomarkers actually increases the odds ratio almost 12.63. In other words, there's a 13-fold increase in the risk of diabetes if you have a higher level of both visfatin and fetuvin, a very powerful tool to predict diabetes in those people with prediabetes. We also found that it can also predict metabolic syndrome, not only diabetes, so therefore they're involved in cardiovascular events. Does the prevention or development of diabetes is associated with a change in the plasma biomarker concentrations? These biomarkers were looked at even at the outcome time, and we found that of all these, chemerin resistance and fetuvin A all decreased when you prevent diabetes. In other words, it looks at if inflammatory markers decreasing reduces the risk of diabetes. We did not find that association with visfatin. So, to conclude, metformin has shown to be one of the safe and effective way of reducing the conversion rate of prediabetes to diabetes, both in the TPP and the Indian Diabetes Prevention Program. We have shown the effects on insulin resistance. The next thing is, does metformin has an effect on inflammatory markers and adipokines? There are many studies to show that. This is the effect of metformin on adipokines in patients with polycystic ovarian syndrome. Following metformin treatment, a significant decrease was observed in visfatin levels compared to the baseline, and serum resistance levels were significantly reduced by metformin treatment. This is another study, which is again showing that pro-inflammatory markers such as interleukin-6 and tumor necrosis factors were reduced by treatment with metformin in those patients who had metabolic syndrome. This is a meta-analysis of all the studies on PCOS where metformin was looked into was associated with adiponectin. And what they found was that metformin treatment was associated with significantly increased serum adiponectin levels, which increased insulin sensitivity. As you know, increased adiponectin improves insulin sensitivity. Additionally, the meta-analysis revealed circulating tumor necrosis factor, TNF-alpha, and C-reactive protein concentrations were significantly decreased after metformin treatment. So, to conclude, postponement or prevention of diabetes is possible with metformin. The improvement in insulin sensitivity and consequent improvement in insulin secretion both are responsible for the prevention of diabetes. The high levels of inflammatory biomarkers, adipokines and hepatokines in prediabetes play a vital role in the pathogenesis of diabetes. In other words, I must say that both prediabetes and diabetes are inflammatory diseases. Metformin is an old wine in a new bottle with multiple targets, including inflammatory markers and adipokines, other than just insulin resistance. So I think we are finding newer targets and newer actions of metformin, which can not only reduce the incidence of diabetes and prevent diabetes, perhaps also reduces the inflammatory process in those with prediabetes and reduce the risk of cardiovascular events. I should thank my collaborators and also my research team. Thank you very much.
Thank you so much.
That's my last slide.
Thank you. Thank you so much, sir. Thank you for taking us through this very interesting world to all these clinicians who are logged in, world of biomarkers, inflammatory markers, something which something we've been using in metformin, and probably a large number of us don't think about it that much. So I'm sure it's very exciting. And now time for the very exciting part that we will have a panel discussion, which will be chaired and moderated by Dr. Sanjay Agarwal, sir. And over to you, sir.
Thank you very much. I think we've had 3 exciting lectures and 3 different perspectives about prediabetes and insulin resistance. And we've seen a whole array of messages that came across from all these 3 lectures. So I'm going to throw open the panel and ask a few questions, which have come forth from your talks. One is, of course, that we always talk about using metformin in prediabetes. The question in a clinician's mind is, when should metformin be introduced? So if you sort of break down the entire duration of prediabetes, let's say into quartiles or tertiles, when should a clinician really introduce metformin? Or should he start with lifestyle and metformin right at the initiation of diagnosis of prediabetes itself? So where would you position metformin? I'll let any of you answer that.
Okay, since no one is speaking, I'll speak. It will generate some controversy, okay? So as I said, prediabetes is a very bad term. Prediabetes is diabetes. It just, the severity of the defects are not to the extent you see in diabetes. And what I'm going to say is, I would say by no means definitive. But of course, the closer your A1C is to 6.5, or the closer your 2-hour glucose is to 200, or the closer the more elevated is your fasting glucose, and the more components of the metabolic syndrome you have, and the stronger is the family history of diabetes, all of these things collectively are going to play into whether you treat someone. So if someone has an A1C of 6.2 and their 2-hour glucose is 180 and the fasting glucose is 105, and they've got 3 brothers with diabetes, of course, that's the person who you're probably going to focus on. And on the other hand, if the A1C is 5.8, you don't have components of the metabolic syndrome, etc., probably you might wait and observe that person. And, based on what Dr. Ramachandran has said, maybe he can put together a novel index. If you take all of these various biomarkers together and you combine them with the A1C, et cetera, maybe we can get a stronger sort of predictive value. So it would be interesting to see if he could put all of those measurements together with the data from the OGTT and A1C, and maybe give us a better score to help us, push us forward as to who should be, treated. So I'd be interested to hear what Dr. Ramachandran said, about maybe using a combined score from his biomarker panel.
I'll add to that, Ralph, and that is, I think giving a cutoff value for hyperglycemia and HbA1c is almost meaningless as far as cardiovascular risk is concerned. I think the risk is a continuum. And as you rightly said, prediabetes is not just a blood glucose being high. it is accompanied by several other associated risk factors, such as I've shown you that the inflammatory markers are very high in pre-diabetes, and they predict diabetes. And if you have, I think it's very unlikely that you see somebody with pre-diabetes with only just a high blood glucose alone. Invariably, they have some of the components of metabolic syndrome. If you see only isolated high plasma glucose alone, well, you can leave him alone with lifestyle modification. But I guess most of them always have mild hypertension, they have dyslipidemia, they have central adiposity, and I'm sure they have high inflammatory markers. So I would say that one of the best options that you have is use something like metformin as early as possible so that you can actually reverse the most of the things that we have been talking about.
Can I add to that?
Yes, sir. Please.
So Dr. DeFranco and Dr. Ramchandran already told a couple of things where we should use metformin. A couple of other conditions where we should use metformin earlier than the usual, and one of them is if there's a history of polycystic ovarian disease, and so you should use metformin earlier. If patient is quite obese, and so BMI in Indians more than 30, otherwise more than 35, then we should use metformin quite early. In my practice, in those people who cannot walk much, they have marked knee osteoarthritis, they're markedly obese, and they have problems, musculoskeletal problem, achieving the lifestyle that we tell them to do, then metformin is the option which should be started immediately. And like Dr. Ramchandran said, that there are multiple other factors. They have hypertension, they have a family history of coronary artery disease, they have pre-diabetes, then we should look at metformin again earlier. And finally, I look at the higher levels of blood sugar. In say, blood sugar is fasting of 120, 125, something. It does touching diabetic, and post-glucose is 180, 190. I would use metformin earlier in these patients than a person who has 105 and 160. So if clinicians can use these guidelines, I think they should be okay most of the time.
So I'll just ask you one, just an extension to this. If you use metformin early, does it sort of slows down the graph of progression of beta cell apoptosis or beta cell failure versus somebody who starts metformin at a later point of time in the same pre-diabetic range? So if you look at early versus late pre-diabetes, does it slow down the progression of the disease in any kind of a way?
It will depend on the phenotype. I've told you five or six phenotypes. Now, some of people are overweight with a normal insulin sensitivity and normal insulin secretion, and if they develop a little high sugar, they are likely to come back to normal glucose regulation pretty fast. Versus somebody who has a low insulin sensitivity, markedly insulin resistant, and low insulin secretion. Now, in these people, it is difficult to attain a better insulin secretion unless they lose weight and their insulin resistance goes down, as Dr. Ramchandran has already shown in his study. So I think it's all question of what, apart from metformin, we are targeting. And apart from metformin, the number one target remains the weight. And if you are looking at weight, then within the weight paradigm, you should look at the hepatic fat and pancreatic fat. And that can be reduced even in normal weight people. So if we are reducing weight and we are looking at the decrease in the hepatic fat and pancreatic fat, then we are looking at improvement in the insulin sensitivity and possible improvement in insulin secretion. Now that may happen with metformin, depending on whether metformin, how much lifestyle person is doing, or maybe we have to do something more for weight reduction.
So I want to come back to you, Dr. DeFranco. If you say that 80% of the cells are lost, during the pre-diabetes, then how does really bariatric surgery or, all weight loss measures tend to help in the reversal of diabetes? I mean, that's a key question that people have in their mind.
Yeah, I didn't say 80% of the beta cells are lost. What I said is that 80% of the beta cell function is lost. That's a totally different statement. So you can, at an early stage, completely or near completely reverse the defect in beta cell function. But if you start to lose beta cell mass as the disease progresses, that's a very different story, because at the present time, there really is no therapy that's going to regenerate beta cells. And in fact, and we've shown this very clearly, the San Antonio metabolism study, the Qatar study, you can take people who have A1Cs that are 10 to 12, 10 to 15 years duration of diabetes, and if you put them on the right drugs, and by the way, metformin is not one of the right drugs. If you put them on pioglitazone and a GLP-1 receptor agonist, in the great majority of those people, you actually can restore the beta cell function. But obviously, there's some point at which you've lost a critical mass of beta cells, and then there's no drug that's going to treat those people other than insulin.
So I'm going to again tease your mind and say that, you've mentioned very clearly in your slides that if you start a triple oral therapy, the conversion rate from pre-diabetes to diabetes is virtually zero. That's from one of your studies.
Zero.
And you've been on so you've been on the chair of number of guidelines. So why do we not start combination therapies early? Why do we still have the age-old, lifestyle followed by metformin? And yet we sort of, do not propagate early, combination therapies?
Because Ralph DeFranco is a lot smarter than the rest of the people on the committee. Or back in maybe the dark ages. That's a very honest, sincere, and correct answer. Now, having said that, if you look at the most current guidelines, 2022, okay, finally, 2022, last month, there is now a section that recommends consideration of combination therapy for initial therapy. Lo and behold, the ADA has come out of the 17th century. They're in about the 18th century now. And interestingly, the two papers that they quote are our study, the IDEC study, which now is in year 6 of triple combination therapy with metformin, exenatide, and pioglitazone, and the other one is the Verify study with Dr. Del Prato. And those are the two papers that they quote. But look, it's taken into 2022. Moreover, if you have 8, probably more anyways, 8 pathophysiologic defects, it's insane to think that one drug can correct 8 problems. If you have cancer, we don't treat you with one drug. We treat you with multiple drugs. If you have hypertension, we don't treat you with one drug. We use multiple drugs. If you are heart failure, we treat you with multiple drugs. The only people who think that you can treat a disease with one drug is the American Diabetes Association. And quite frankly, they really have been laboring in the 17th, 18th century. And that's unfortunate. But at least we're now starting to see a change based on the current guidelines.
So, Dr. Ramchandran, I want to also come back to you. We are going to be revising the RSSDI guidelines this year. And what would you recommend for the Indian population? I mean, should we still follow the, lifestyle followed by metformin, or should we advocate for the Indian population early combination therapy? And if so, what do you think the Indian population would be best suited to? Pioglitazone, metformin, DPP-4 metformin, or as Ralph said, pio metformin plus, GLP-1 analog?
Okay, thank you for the question. I think the first thing is that, as you know, that the BMI of Indians who have pre-diabetes is 25 compared to 31, 35 in the Americans. So there's not much make them to lose weight, and we don't. So therefore, and the second thing is the conversion rate is 2-fold higher from pre-diabetes to diabetes. So there's every reason that we have to actually be more aggressive to prevent diabetes in the Indian population compared to the white population. That's number one. The second point is that the DCLIP study is a good example in which they use lifestyle modification, and the protocol of the study was that you use lifestyle modification and there is not enough response within 6 months, if I remember right, you use metformin. And in 70% of the patients, they ended up starting metformin. Finally, it is a metformin trial, not a lifestyle modification trial. The last question that you asked is whether you should use a combination of pioglitazone and metformin. That is a problem. I have a different opinion, and Ralph knows this. We have an Indian study published before ACT now. We're using pioglitazone in a randomized double-blind control study. In we choose 15 to 30 milligrams of metformin in non-obese Indians, well-powered. Unfortunately, there was no significant relative risk reduction of diabetes was not significant in those patients with pioglitazone. I do not know whether there is any difference in the mechanism of insulin resistance between the thin Asian Indians compared to the fat white Americans, where their pioglitazone is working, here it is not working. Maybe Ralph knows the answer, I don't know. Of course, I think he knows my paper.
Yeah, so I'm very well aware of the paper, and I have to say it's the one anomaly in the entire world's literature. There is no other paper that has ever shown a result like this. You can look at the entire European literature. There are many studies with pioglitazone in both lean and obese people. There are studies from China. There's studies from Japan. There's studies from the US. So this would suggest that there's some unique genetic differences between the Indian population. And of course, one of the things that we didn't discuss is that all of these results and studies have to be interpreted based on ethnic differences and results in the country where you're at. If you have a study in India that shows that pioglitazone doesn't work, of course, that would influence my decision very heavily. But in the United States, Europe, and elsewhere, pioglitazone has been shown to be a phenomenal drug with 70 to 75% reductions in the conversion rates. And also we have, as I said, the IRIS study in the US, where these people were relatively lean, BMIs 28 to 30, where not only did we see a dramatic reduction in pre-diabetic as well as normal glucose tolerant individuals in the conversion rate to diabetes, but we see a dramatic reduction in cardiovascular complications. So clearly there probably are some ethnic genetic differences in populations, and they need to be taken into consideration.
I have a very interesting question, and I'll put this to all three of you. The question reads from one of the audiences. I think in all three presentations, pre-diabetes was heavily confounded by obesity adiposity. In the PMNS, we have 30% prevalence of pre-diabetes in 18-year-old rural participants. A third of these boys had a BMI of less than 18.5, and 2/3 of them were girls. The major abnormality was low disposition index starting from 6 years of age, not insulin resistance. These participants also had poor linear and liver growth in utero, but larger liver at 18 years of age. Conventional thinking doesn't seem to apply to these native populations, which I think is a pure pre-diabetes model, not contaminated by obesity adiposity. I think this question is from Dr. Yagnik to you. So would you like to comment on this?
Let me just give my comment, although I may not be the best person, because if it's Dr. Yagnik, he has studied such individuals the most. I feel that, and I have put some slides in my presentation, so it's not all presentations are obesity laden presentation. I have clearly put number one, where Indians develop diabetes, and I have also clearly put that non-obese people may have low insulin secretors and may have problems as far as conversion back to normal glucose regulation is concerned. These are the non-obese or not even non-obese. They are undernourished people, a BMI of 18.5, where something is happening and nobody knows what is happening to their pancreatic beta cells and liver. And so both are problematic. And so they may be having a poor insulin secretion, like it has been mentioned, and the pre-diabetes is majorly driven by the insulin secretion rather than insulin resistance, and which it's a major driver, and which is a difficult thing to handle actually ultimately, because if it is not treated, it will continue to decline and diabetes will occur very soon. So this kind of phenotype is not, if you say it is common, no, it is not. If you are sitting in Delhi, I'm not seeing this phenotype in 95% of the people, maybe 5%, and those are coming from the faraway rural areas. But if you are sitting in Orissa, or if you are sitting in Bangladesh, or some parts of rural Bengal, you will see plenty of things. So there is heterogeneity in non-obese people. And recently there is a very good paper from Dr. Nehal Thomas group published in Diabetes Care, where this particular problem has been majorly investigated using state-of-the-art. I think everybody should go through that paper, excellent paper, and multiple groups are involved in that paper. So we have yet to define this phenotype. Yes, it is a difficult phenotype. It is found in some places in India, and it needs certainly more research.
Thank you, sir. And I'll come to the last question because we're running out of time. And I'm going to ask this to Dr. Ramchandran, that you talked about improvement of biomarkers. And I'm just going to ask you a very basic question. What improves it best, lifestyle modification, metformin, or early combination therapy, has an impact on biomarkers the best?
Yeah, I think when you prevent diabetes, you actually definitely improve the biomarkers by lifestyle modification. But however, we have found that the only drug which can actually specifically improve biomarkers is metformin in most of the studies. And that is what it's shown. It is not from my study alone. I'm talking about this meta-analysis in PCOS and in metabolic syndrome. It was found that metformin can reduce the higher levels of biomarkers, especially pro-inflammatory markers, and improve adiponectin. But whenever you improve insulin sensitivity, it is usually associated with an improvement in adiponectin, and that actually reduces the risk of diabetes. But interestingly, the other risk biomarkers are not only involved in hyperglycemia, but they're also involved in inflammations and producing even cancer, etc. So therefore, as Ralph said, pre-diabetes looks to be a little complex phenomena, complex problem. It is not just high blood sugar. So coming back to the point with which Anup was answering Ranjan's question on the thin people having pre-diabetes, that is because we have defined pre-diabetes only with the blood glucose or HbA1c. Perhaps the pre-diabetes that Ralph is describing and what we are seeing in the urban population is more complex than that. It is not just high blood glucose alone. It is associated with inflammation, is associated with other cardiovascular risk. And therefore, a specific drug like metformin, which has got specific action on those targets, will be perhaps very useful.
So, Ralph, I'm going to ask you the same thing. Metformin or metformin plus pioglitazone, in your opinion?
Oh, I mean, there's obviously an ethnic difference. I can't argue with the Indian study, okay? But everywhere else in the world, pioglitazone would destroy metformin. Moreover, there's a lot of misconceptions that have been brought up in this presentation. Metformin is not an insulin sensitizer. Under no conditions, it is absolutely impossible to be an insulin sensitizer. Metformin, as I said, gets into muscle cells through the organic cation transporter. The organic cation transporter does not exist in muscle. We and others have done PET studies. You can label the metformin with carbon 11. When you give metformin, the only place that you can see metformin go is in the liver. And I don't really care whether that's India, China, Japan, Europe, United States. I guarantee you that metformin does not get in the muscle. And it is not an insulin sensitizer. We've done this extensively with the insulin clamp. All of these data was submitted to the FDA for the approval of metformin. And if you use the HOMA IR and the HOMA beta, you will get absolutely incorrect insights. Metformin works on the liver, and that is the only place it works. And we've also looked extensively at what happens to the beta cell. There are no direct effects on the beta cell. There may be indirect effects because you suppress hepatic glucose production, and the fasting glucose and postprandial glucose goes down, and you secondarily reverse glucotoxicity. But in my opinion, there are no direct effects on the beta cell. And I would challenge anybody to show me data that metformin works any place other than in the liver. It's a good drug. I like it. And we know that it works. But I don't believe that its mechanism of action has anything to do with improving insulin sensitivity in muscle. That I'm 100% sure.
Dr. Ramchandran, you want to make a quick reply to that before we
Well,
end?
it definitely improves insulin sensitivity, but it may not be through the muscle, perhaps. Maybe it's most working on the hepatic tissue and adipocytes. That may be the reason. I don't know.
Yeah. Well, I doubt it works on hepatocytes since we've done these turnover studies with C14 fatty acids and glycerol, and there's absolutely no effect on the adipocyte whatsoever. Its only effect is on the liver. And if you use HOMA IR and HOMA beta, you are guaranteed to get the wrong answer. Absolutely. So the way the mistake comes about is that metformin works on the liver. It suppresses hepatic glucose production. The fasting glucose declines. When the fasting glucose declines, the fasting insulin follows the glucose. So you get the false impression that from HOMA IR, and it's clearly false, that you get an improvement in muscle insulin sensitivity. You do a clamp on those people and you'll show there's no improvement in insulin sensitivity. And moreover, because the glucose drops more than the insulin, it looks using HOMA beta, which is a completely worthless measure, by the way, you get an improvement in insulin secretion. And that is also false. And the worst thing that you can do is to take HOMA IR and HOMA beta and put those two together to come up with an index of beta cell function, and you'll universally get the wrong number. So I think there are lots of misconceptions in the literature by people who don't really understand the physiology and how these drugs work. Now, does metformin work? Of course it does, okay? We know it does, but its primary effect is on the liver. And if you want to understand the physiology, you must be doing sophisticated measures like hyperglycemic clamps or insulin clamps to sort out what's going on. Now, in terms of the anti-inflammatory story, that's a totally different story. There clearly are a number of effects on these biomarkers, which are important for the other aspect of diabetes or prediabetes, which is the atherosclerotic cardiovascular side of the story. But I don't believe that the potential atherosclerotic benefits are related to an improvement in insulin sensitivity in muscle, because you just don't see it.
Dr. Mishra, you want to add a last comment?
No, nothing much, except that I agree totally with Dr. DeFranco that it is acting primarily through liver. Recently, we are in the process of doing a study where we are looking at the liver fat using a proton density MRI fraction, and with the use of metformin. The preliminary data show, and you know, it's interesting to know that nobody till now has looked at the liver fat in a greater detail with the use of metformin. Such an old drug, and nobody has done, and everybody has researched every other drug. We are looking at the data, and I have a feeling that in Indian patients versus any other, the metformin may be acting better as far as the liver is concerned, and it may be reducing liver fat. And we will have that data soon, and we'll have a paper soon. But that is my feeling, having looked at this data in a preliminary manner. If that is so, that is additional effect of metformin, which may improve overall metabolic milieu without working on anything else. just liver, its fat, and its metabolism. And so we will see about that. And that will give impetus of using metformin more in Indian patients.
I think, all this interest has been generated because the DCGI, as Dr. Ramchandran just mentioned, approved, metformin for prevention of conversion to diabetes. And I think that's going to be a very big game changer when it comes to Indian population and treating diabetes. So I think all good things have to come to an end. The discussion can go on and all. I've got a huge list of questions still lined up, but I think we've run out of time. Such has been the impact of all the three speakers today that, it's invited so much of discussion on the platform and people have been commenting and passing questions. I'm sorry that I have not been able to address most of the questions that were, sent to me, but I'm sure we'll try and address at some point of time. So thank you very much, all the speakers, for doing such a great job. It's been such a lively discussion. And I want to pass this back to Archana for the final, vote of thanks and, acknowledging everybody who's been part of the show to make it a big success.
We will meet in New Orleans 2 weeks from now.
Yes.
Yes.
Finally, real people.
So before we end this absolutely exciting evening that we have 2,000 clinicians logged in at this time of the night, listening to every word that our esteemed speakers have been sharing with us, I will hand over to Dr. Neeta Deshpande for concluding the learnings of today and her view on what has happened today. And after her, I would request Shilpa to please give us a formal vote of thanks, because that is something as valuable as the rest of the program. Over to you, Neeta, and then Shilpa. You're silent. Yes.
Thank you, Archana. And it has been an absolutely exhilarating academic session for sure. And as all great academic sessions do, this academic session also has thrown up more questions than answers. And definitely that gives us a lot of food for thought, a lot of, issues to research and do more and more work. And I really appreciate and thank our three excellent speakers, real stalwarts in their own field, for being with us this session. And I hand over to Shilpa to propose the vote of thanks.
Thank you, Neeta. So after this stimulating discussion, it's time for vote of thanks. So on behalf of Team IDEC, I would like to thank our elite speakers today, Dr. DeFranzo, Dr. Ramachandran, and Dr. Arup Mishra, who have spared their valuable time to discuss prediabetes and insulin resistance and metformin. I would also like to thank audience, because it's almost 11:15 at night and questions are still pouring in. So I would like to thank them for their enthusiasm and a lot of discussion with the speakers. And last but not the least, I would like to thank USV for their support for this event. We hope to meet all of you for more IDEC cafes with hot brew of hot and burning topics hence on. So keep logged in and keep in touch. We'll have more such discussion. Good night and good day to all of you in USA.
Thank you.
Okay,
Thank you
good
very
night.
much.
Good
See everybody in New Orleans.
Thank
Ciao,
you.
ciao.
Good night.